Well, good morning, everybody.
Morning.
Morning.
oh, Okay. Everybody can see the big screen, is that right?
We see you actually.
You
We
see
don't
me?
see the screen. Yep.
Okay, well, that's a problem. Maybe I have to hit the button that says share, then. How's that? You see it
Now
now?
we see it. Yep.
Is that the voice of Sergey Bebia?
Yes, he is.
Welcome back.
Thank you.
Missed you. Good to see you back virtually, though real. Okay, so what I thought today we would do is go over review a case that we did recently, not too long ago, which is one of ablation in a small child. Okay, so the child was 3, had a history of SVT, actually was diagnosed in fetal life with SVT, and mother was treated with flecainide with good control. And the child was born at 3 kilos and was treated with flecainide at a dose of 75 milligrams per meter squared per day, divided TID. You remember that officially or formally or just physiologically, flecainide should be dosed TID up till about age 10 to 12 because of the half-life of the medication. Some people do still dose it BID, but it is essentially leaving the child unprotected for periods of time. And on this medication, the child had no SVT. And as is usually the case, when he was 8 months of age, we were now down to 70 milligrams per meter squared per day. We had been increasing it slowly with time, but a Holter showed that there was no SVT and the flecainide was discontinued. As you know, the most common time that we would typically stop therapy would be about a year of age. And may have, if you've listened to my podcast a couple of months ago, we reviewed a paper from the group in San Diego showing that actually there's nothing magical about 12 months. And in fact, I think the average electrophysiologist stopped at about 6 months. But so anyway, we stopped at about 8 months, but we did. And so we were watching the patient and they came into the office, and this was the 12-lead ECG when they arrived in clinic. So why don't I ask Dr. Bonsall, what do you think about this ECG in terms of tachycardia mechanism, or is it sinus tach, for example?
Good morning, Dr. Bass.
Good morning, Bernard.
It's not sinus.
Okay. True.
Just trying to look at the 1, 2 AVF. Yeah, P wave morphology is not sinus. I'm trying to look at the leads. I see the P waves very close after the T wave. If I'm looking right now, I'm looking at the
You're referring to like over here.
yeah.
I agree with that statement.
And obviously this is a 10-month-old. Our rate is close to 200 or 170, 200, yeah.
It's about 180 beats per minute.
Yeah.
So what do you think about an SVT in an infant who's 10 months old at a rate of 180 beats per minute, who is on at this point no medication?
That is slow.
Correct.
I would, if it was like proper SVT, I would have expected rate higher.
How high? What would a normal SVT rate typically be for a child of this age, usually, roughly?
250 or above.
Yeah, exactly. So this is somewhat slower than average. And what do you make of the R to P interval? Is this a short RP interval, a usual RP interval, or a long RP interval?
I would say the RP interval is about 5 small boxes. So about 200 milliseconds. So it's a long RP interval.
Right. So we have a long RP interval with a relatively slow-ish tachycardia.
Mhm.
So what is the differential diagnosis, do you think, of this?
So it could be, so we had discussed last time, long PJRT with long RP interval,
Yeah. Yeah. What else could it be?
AVNRT.
You mean like atypical AVNRT? Because
Sorry,
what
AVRT,
oh,
AVRT.
AVRT, so or ORT.
Mhm.
Yeah, but what's the RP interval usually like in a patient having ORT?
It is more, so it's more than 70, but it's up to like 150.
Right. So it's a little bit of a longish RP. And you just earlier told me that, I mean, the most common cause of SVT in young infants is ORT, right? And usually the heart rate in ORT, you said, is 250 beats per minute. So this would be a very unusual form of ORT. But I guess it could be. But usually when we have such a long RP interval with a slow tachycardia rate, we call that PJRT, not ORT. Anything else this could be? What about primary atrial arrhythmias?
So EAT.
Yeah, this could be EAT, right? You could have an ectopic focus that's just firing at a certain rate, and the RP interval is just sort of an innocent bystander. And then I guess it could be atrial flutter, but atrial flutter, have you ever heard of atrial flutter at this type of a rate in a baby of this age who has had no surgery or anything like that?
No,
No,
I have
because
not.
this basically doesn't happen. Usually, the only flutter we see in patients with structurally normal hearts, which you've discussed many times, is in newborns, right, where the atrial rate is like 400 or 500 beats per minute or more. This is clearly not that. You could potentially invoke a 2-to-1 mechanism, but if you look carefully, I think you'd agree there's not obvious evidence for buried P waves anywhere in this. So this is a 1-to-1 type of tachycardia. So the most likely diagnoses for this are either PJRT or EAT. Okay, good.
Dr. Bass, question.
Yes.
So when we talk about automatic arrhythmia, we talk about like slowly picking up and like warming up.
Yep.
But if they come into your clinic and I mean, I don't know how to determine, but like if it was an older patient who did not have any symptoms, and then you do an EKG and you see like a rhythm like this, would you still think of EAT? Because like because they've not they would have known, or could it have an onset like an accessory pathway?
When you say an onset like an accessory pathway, are you using
Like,
that terminology to suggest a rapid onset?
yes,
Okay.
exactly.
Yeah. Well, so yes, it's true that we always say that EAT, being an automatic tachycardia, should have a slow onset and similarly a slow offset. But interestingly, a lot of EATs have triggered automaticity, which is a type of a mechanism that we don't really talk about very much in this conference, because I'm trying to give you broad principles upon which to understand EKGs. But that is the third mechanism of tachycardia, which is a form of automatic arrhythmia, but it can be triggered by premature beats. And so, in fact, EATs can sometimes start suddenly with a PAC. And in fact, we rely on that fact when we're doing EP studies to ablate them, to try and induce them by pacing maneuvers. But in this case, of course, you don't really know when this started, right? This is a 10-month-old. He's been off his medication at this point for 2 months. Josie and I are seeing this in the office and are a little nervous because we don't know how long this has been going on. And this is, in fact, why patients get into trouble with EAT, terms of cardiomyopathy or PJRT, which is that their heart rate is fast, but it's not a fast like a patient is going to have a cardiac arrest. But if you sit at this type of heart rate all the time, it can absolutely result in tachycardia-induced cardiomyopathy. So this is a worrisome EKG. Now, in this particular case, because we knew that the child had been very well controlled on flecainide in the past and also had never had any pro-arrhythmia on flecainide, we resumed the flecainide and noticed that there were a few breakthrough episodes between doses. And this was the Zio that we obtained shortly after we resumed it. And I saw that there were multiple episodes of tachycardia. And I said they represent either EAT or PJRT, but the predominant rhythm was sinus. And so at that point, because the child was just old enough, we were able to switch to tablet form. And I think in retrospect, we were concerned that the child was getting different doses. And once we went to tablet form and was getting an exact half tablet, the child never really had tachycardia again and had very good control. This was the Zio normal sinus throughout after we did that. So we're sort of puttering along, but the family is not happy with me, Dr. Pass, because I have, probably because I told them that most of the time tachycardias get better by the time you're about a year of age, and this one did not. And so that clearly seemed to create some concern in the family that I was not as knowledgeable as I was. And so they went for a second opinion. And this is what the second opinion said. And it said, it is my impression that the patient has a long RP tachycardia that could be related to PJRT or EAT. I believe that this is likely PJRT because of rapid termination with the P wave. Regardless of the mechanism, he's well controlled on the current dose of flecainide. I discussed with the parents the natural history of this problem and the possibility that he might outgrow the arrhythmia, which is less likely as he gets older and continues to have it. I explained that in the future, he could have an ablation that will cure the problem. However, as long as he is well controlled, I would wait until he is older than 5 years of age. I explained briefly what an ablation is in terms of follow-up. I would get a Holter, an echo, documenting normal function. I suggested a pulse oximeter. Mom has been using a stethoscope, but she has difficulties using it. I also discussed that we could consider changing the flecainide to BID, which she's suggesting because of ease for the parent, and repeat the Holter since the mother expresses. And the mother had expressed a difficulty with TID to us, but as I explained to you earlier, in between doses at the lower dose, the child was having episodes. So I was not too keen on BID dosing in this patient. It was very sensitive to the medicine. So the patient did well, was now 3 years of age, had had no SVT on 3 Zio monitors, and was weighing about 15 kilos and was taking about a half a tablet with good control. But the problem was that he had grown and he would now need an increase in his dose, which was more than half a tablet, but less than a full tablet. And so we were going to be forced to go back to a solution. Now, there's nothing wrong with the solution, but as you know, I've explained to all of you that I've seen toxicity sometimes with flecainide solutions. And so I decided with the family that we would attempt to ablate this. Since he was 15 kilos, we would make a conservative attempt. So now we'll go through the ablation. So this is the baseline EKG, and we see that the child is clearly in sinus rhythm with an upright P wave in 1 and an F. This is at 100 sweep speed. And we start all our cases, as you know, by measuring the AH and the HV intervals. So the AH interval is 61. So Tarek, what's a normal AH interval normally in human beings? I don't know, Tarek, can you guys hear me?
Like up to 150, like 50 to 150.
It's really about 120, I would say,
Okay.
50 to about 120, right? So, and then what's a normal HV interval? In this case, the HV interval was a 46. 45.
Yeah, like 35 to 50.
Right, 35 to 50, exactly. So this child has a normal AH and normal HV intervals to start. And again, we always do that at the start of every case because we sort of want to know what our baseline is so that we can compare it to the end of the case to make sure that we didn't cause any injury or problems. So here we are. Typically, we will start the case with atrial pacing in order to stress the node and assess AV node function and also potentially to induce tachycardia. So we're pacing at cycle length 400, which as you know is a rate of 150. And now we're pacing, we're coming down. Josie's lowering the cycle length. We're now at 350 milliseconds. We're still conducting one-to-one. Notice that the AH interval is lengthening, which as you know is a sign of so-called decremental conduction in the AV node. You notice also that the PR is starting to get longer than the RR because, you know, here the pacing spike in the atrium is sort of just after the QRS, very long AH interval. But eventually we see that this pacing spike is even before the onset of the QRS. So it looks like we're going to have dual AV node physiology, but in fact, we see here that so this beat goes to that QRS and this paced A does not go to any QRS. And then there's another beat. So this is an example of Wenckebach. So we're Wenckebaching at about cycle length 300, which is a fairly normal Wenckebach cycle length, especially in a child under anesthesia of this age. So then our usual approach then is to do atrial extrastimulus testing. Again, we're testing the node and we're also trying to see if we can induce tachycardia. And as you know, we pace at a drivetrain of a certain cycle length, in this case 400. Usually in small children, the drivetrain has to be faster because the child's resting sinus rate is faster. And then we put in progressively earlier and earlier extra stimuli after 8 beats of the drivetrain. And in the interest of time, we'll just go from 360. Now we're at 290, and we see that we are seeing decrement in the AV time, suggesting that there is not an antegrade accessory pathway, right? Because AV nodes are decremental and accessory pathways are not. Here we are at 270, and we see that the AH is getting a little longer still. Then we're at 260, and it's even a little bit longer still, measuring from the A to the H in the His channel. Here we are at 250, AH getting even a little longer still. We'll drop down 2 to save time. We're now at 230, AH getting even a little bit longer still. Here we are even at 220, and we're still getting lengthening in the AH interval. Interestingly, there seems to be one PAC immediately after that beat, but then we're back in normal sinus rhythm. And then here we are at 200 milliseconds, and we're still conducting through the AV node. Now, we have not really reached the AV node ERP, but I don't want to go any lower than this for fear that we might induce something like a fib. So I usually will ask that we stop doing extra stim below 200. So what we would say here to describe the AV node ERP is that it is less than or equal to 400, 200. Okay. All right. And so the AV node is doing well, but at this point, we still do not have any evidence for tachycardia. So now what we're trying to do is just induce, I should tell you, I didn't show it to you, but there was no VA there is no VA conduction. So that would suggest the possibility of this being EAT, right? Because usually people who have retrograde conduction, in order to have PJRT, you would have to have VA conduction. So now we're pretty clear that this is EAT, but we don't have any EAT yet. So now we're doing a double atrial extrastimulus testing, trying to trigger this focus wherever it is. And then finally, with some very tight atrial double extrastimuli, we are able to induce tachycardia. And so let's just look at this tachycardia briefly. So in sinus rhythm, the high RA should normally be earliest, right? But in fact, what we see here is a very abnormal pattern in the coronary sinus. So we're going from CS proximal, more distal, and we see that the distal CS is actually earlier than any of the other coronary sinus pairs. Similarly, the high right atrial signal is very late in comparison to the onset of the coronary sinus pair. And also this is the mapping catheter, which is just sitting in the low right atrium, is also later than the onset of these signals in the coronary sinus. So David, what does that suggest to you regarding the general location of where this pathway where this focus might be?
So left-sided focus.
Yeah, that's correct. And so this is the 12 lead EKG at 100 paper speed. And I think you would agree that we clearly do not have that nice clean sinus rhythm that we had before. So based on whenever we have a tachycardia like this, an automatic arrhythmia, particularly one that's taken a while for us to induce, the second we see it, we start to map, because we're always concerned that it's going to spontaneously stop and then we won't be able to do anything. So here we are, and we decided that it's time to activation map. And so we used a new technology. It's not actually that new anymore. It's been around for about 5 years or so, called a Penta Ray catheter, which has 10 electrode pairs. You see here's one pair, another pair, et cetera, et cetera. It's got 5 splines on it. These are very, very soft. And what's very cool about this catheter is that it records the signal and the location of the signal simultaneously on CARTO. So when you are in tachycardia, you can basically gently place this against the atrial myocardium, and the computer will record the signal that's recorded on every single electrode pair here. Not only the timing of it relative to a fiducial point that you choose on the P wave, but it will also record where the catheter was at the time. The other interesting aspect of this is that the spacing between the electrodes is tighter than on a typical bipolar catheter, so that the theoretical accuracy of the earliest site should be even greater using a catheter of this nature, because it's recording a smaller location than you would with, say, a standard radiofrequency ablation catheter. And so we got that catheter out. And really, the goal of a so-called activation map, excuse me, is that we have to compare the local activation of the atrial myocardium in comparison to the onset of the P wave. And the earlier the local electrogram is relative to the onset of the P wave, the closer the catheter is, in theory, to the locale of the origin of the EAT. Okay, and traditionally, this is done with a single catheter going point by point by point. And if you know exactly where in the atrium this is going to be coming from, you can do that fairly accurately just using an ablation catheter. But if you don't really know where it's coming from, it's helpful to do this. And the benefit of this is that the recordings from the Penta Ray are automated. And so you can, whereas with a standard ablation catheter going point by point, it could potentially take you 25 minutes to get 50 or 60 points. This thing will take a few hundred points in just a few minutes. So in theory, this is a major advance. And this catheter was designed for atrial fibrillation ablations, but we're using it in another manner. And so we started with the Penta Ray map of the right atrium, and in probably 3 to 5 minutes, we got between 300 and 400 locations in the right atrium. This is really remarkable. We never could do this in the past this quickly. And unfortunately, I don't have a Carto image without the left atrium in it. We'll go over that in a moment. But the way that Carto works, as you know, is that the cooler colors, the blues and the greens, are later, and the hot red colors are earlier. And I think you can clearly see. So when we were just in the right atrium and we did not yet have access to the left atrium, what we saw was that at the mouth of the coronary sinus, there was like over here, this was the red, and everything else was later and later, the more farther away you were from this, and that was usually just a demonstration that the right atrium was passively depolarizing from an impulse coming from the left atrium and breaking through the coronary sinus, and then essentially depolarizing the atrium in a retrograde fashion from the low right atrium. So the other thing that we noticed was that all of our right atrial signals, as I mentioned earlier, were late. And again, we see here that the earliest electrograms are clearly in the left side, and all of our right atrial signals were quite late. So in fact, when we only had the right atrial signals, and we were not yet in the left atrium, every single signal recorded in the right atrium was what we would refer to as post-systolic, meaning that it was later than the onset of the P wave. And that was very good evidence that the impulse was not coming from the right atrium. It was in fact coming from the left atrium. Okay, so all the RA signals were after the P wave, and the RA was being passively depolarized from the left atrium. And so based on this, we knew that it was time to go to the left atrium. So we performed a Brockenbrough transeptal puncture in order to get into the left atrium. And this particular patient, my recollection is it was, for some reason the movie's not playing, but it was actually very challenging, very thick septum in this particular young patient, but we did ultimately get through. And so once we were through, we then mapped the tachycardia again with the Penta Ray catheter. And what we learned immediately was that all of the signals in the left atrium were earlier than the right atrium. And in fact, you see here, as denoted by the color, blue and purple are even later. And so the entire right atrium becomes blue because the left atrial signal, every single signal in the left atrium was either on time or before the onset of the QRS. And this area here where the asterisks are, which was sort of in the left lateral mitral annulus area, seemed to have signals that were substantially earlier than the onset of the P wave. So again, we replaced the Penta Ray at that point. Once we had identified the early, so at this point, I'll go to Ziad, our representative from Carto, and I will ask him to identify for me the earliest location as demonstrated by the Carto map. And I'll ask him to place a dot on that spot so that I know, that's the general area we want to go to. And if the Penta Ray has gotten enough points, in theory, we should be able to put the catheter directly at the location of the earliest site, and it should work. The other interesting thing is, as I mentioned earlier, because the ablation catheter is so much larger than the electrodes on the Penta Ray, typically when you bring the ablation catheter in, the site of earliest depolarization seems very small in comparison to the tip of the catheter, which is kind of a nice feeling because it feels like you don't have to be quite as precise. Of course, you're being very precise, but the catheter is burning just that site as well as a little bit to the left and the right because of its size. So we then bring the ablation catheter in after now we have like 300 to 400 spots on the right atrium, a similar number of recordings on the left atrium. The entire initial map of the LA, again, only takes about 3 to 5 minutes as we move it around. And typically the rep will tell me, this part of the atrium you haven't been to yet. And The most common location that EATs arise from in children on the left side is towards the mouth of the pulmonary veins, but in this particular case was actually on the mitral annulus. And so we moved the catheter over to the area of earliest sight, and we see this is Josie recording the timing from the onset of the P wave to the onset of the local electrogram. And you can see that we're on the annulus because we have both an atrial electrogram and a fairly large ventricular electrogram. So in fact, I was a little bit even ventricular word with this signal, but we have a nice clear atrial electrogram. And as a general rule, you want to be at least 30 to 50 milliseconds prior to the onset of the P wave. That has generally been a degree of earliness or that is associated with efficacy. So we mapped around and went a little to the left, to the right, above, below, and ultimately this location at minus 60 milliseconds was the earliest that we could identify a spot in the left atrium. And we turned radio frequency current on our very first application. And you can see here before we go on how early this signal is relative to the onset of the P wave. And basically after one beat of tachycardia in less than 1 second, 600 milliseconds, we immediately flipped to sinus rhythm. And as you know, the tachycardia, of course, immediately stops. Now, generally speaking, and I should just, before I go further, we should, you can clearly see the difference in the surface electrocardiogram when with tachycardia terminates versus tachycardia. We also see that the intracardiac electrograms have changed quite substantially. Now, all of the atrial depolarizations in the coronary sinus, which previously were earliest in the distal CS, look more usual. Also notice how in tachycardia, the right atrial depolarization is very late relative to the onset of the left atrium, as demonstrated in the coronary sinus. Once we're back in sinus rhythm, the right atrial depolarization is now earlier than the coronary sinus. So there's a sudden flip. And as you know, the earlier or the faster that we see a tachycardia go away, the closer we believe that the catheter is to the site. In a perfect world, we would like to see termination as quickly as possible. Generally speaking, using a standard radiofrequency catheter, we'd like to see it go away in under 2 seconds. So for it to go away in 600 milliseconds, particularly on the first application, is a demonstration of the power of this type of catheter, this Penta Ray, as well as our own patients in sort of being selective in identifying the best location before we turned on. And this actually is the surface electrocardiogram, and we see the RF goes on, and then we quickly go to sinus rhythm. And this is this is what it looked like on fluoroscopy. So we have our transeptal sheath. This is the right atrial catheter. This is HIS catheter, coronary sinus catheter. I think we had, actually, I'm sorry, this is the right atrial catheter. This is the RV catheter, and we pulled back the HIS catheter at this point. And here we are with the ablation catheter. Actually, the HIS, these are not simultaneous, but this is the HIS. And anyway, here is the ablation, and we see it's in the left atrium, pretty left lateral on the left mitral and lateral mitral annulus. And we were able to ablate this tachycardia. All right, any questions about this? I thought it would be useful today to go through this because we sometimes when we're doing these things, we have to move very quickly because we're always worried that the tachycardia is going to terminate at any moment and we won't be able to reinduce. This could be this case demonstrates why these types of ablations can be very challenging. In this case, we were lucky in that he had a lot of tachycardia, and so having him off of his flecainide for a few days, it didn't require a lot of effort to get him to go back into his arrhythmia. And that was part of the reason that I was willing to try and proceed. But sometimes in older children, they may not be as aggressive, these arrhythmias. And so classical teaching is to try and do these in patients awake when they have a high adrenergic tone, in order to enhance the chances that the patient is going to actually have their SVT or their tachycardia. Because as you can see, without the EAT, we cannot ablate this arrhythmia. The patient must be in their arrhythmia. And so this is so if we had failed, if we had gone to the lab and we had been unsuccessful in inducing the tachycardia, we probably would have I probably would have put him back on meds and say, we're not coming back until he's old enough to do this awake, which means we would have to wait probably at least 10 years to ablate this. So we were lucky in that he had tachycardia, and similarly lucky that we were able to identify where it was. All right, so I guess if there are no further questions, why don't we stop at this point? And I guess I'll see everybody. We're going to have an interesting conversation about Epstein's anomaly at 8 o'clock, because we have an interesting patient coming up soon. So if anybody have any remaining questions before we end?
Thank you.
Okay, I guess so. Thanks, guys. Have a good day. Be well.
Thank you.
Thank you.